Hello. Welcome everybody.
How are you doing today?
Yeah, I'm good. I'm getting over being sick. So if I start to cough too much, I'll mute myself and
There you go, and there you have it.
yeah, Lauren will take over.
I'll just take off. Hopefully, we're mind melded enough that I can just pick up whatever you were saying
Yep.
and run with it. Meanwhile, I am trying to get us on to Instagram. So if you give me just a moment, because it's a little bit of a trial and error here, folks. I'm
Yeah.
not gonna lie. So do you maybe want to, I guess we could like sort
Yeah.
of
Do you want me to
start.
talk while you're doing that?
Sure.
Okay. So maybe we start. So today we're going to talk about health anxiety, if you couldn't tell by the banner below. But it's probably important to differentiate between health OCD subtype and illness anxiety disorder or health anxiety.
Yeah.
So,
To
well,
the
yeah.
Yeah, I was going to say to the extent that you can, right?
Yeah, I mean, here's the reality is it's like splitting hairs. So, at the end of the day, they might present slightly different. I don't it's doesn't really matter because you treat them the same.
Correct.
In terms of like how it impacts us. Like some people would say that, well, let's start at the beginning. So health anxiety is more around the fear of having a disease, whereas health OCD is like the fear of what if I get a disease, like contract AIDS or something to that effect.
Right.
Or,
Right.
Contamination variation, like what if I'm getting a cold or flu or
Yep. Yeah, and to your point though, it's like this is where it branches off, right? So you can have you can have more stereotypically if you're having OCD around health, we think of contamination with HIV being a big one of those things for some reason. But then to your point also that like when it's health about, I don't know, cancer, we tend to group that with illness anxiety disorder. And then if it's norovirus, we sometimes lump that in with emetophobia, which is the phobia or fear of vomiting, right? So as we've discussed probably an obnoxious amount of times on here, there's just so much overlap that these containers that we're talking about don't really matter.
they cannot
Except
be contained.
they cannot be contained, except for the fact that they matter because they're helpful in supporting people in sort of navigating their own experience. Because right, like if you have this this subtype, you're going to see other people, hear your own experience. That's going to be helpful in just normalizing what you're going through. Yeah, because I mean, I could see an argument made for what if I contract or contracted HIV, and it could be the same with other health issues too. It could be
Absolutely.
like, what if I get it in the future, or what if I have it now? Like
Right.
it's
I know.
all, yeah.
It's silly. That it's just probably what happened is a bunch of doctors got together and they're like, there's these people that keep showing up at my office saying that they have cancer and they don't, and they want lots of reassurance. But the reality is that's not any different than a subtype of OCD.
No, it's not. I one of the things I tend toward, and I don't know if you agree with this, is that if somebody has multiple subtypes, including, and one of the subtypes includes like some form of OCD, like other form of OCD, then I might give them an OCD diagnosis because it's just like a catch-all versus somebody who is just presenting
Right.
with
Same.
fears. Yeah. Yeah. So,
Same.
but same.
Yeah.
So what obsessions have you seen come up in the course of your work around this particular theme?
I've seen so many. So many.
So many.
It could be HIV, AIDS, it could be cancer, it could be a blood clot, it could be what's the one with where like I think marathon runners get it and they deplete their cortisol or something. It's some type of disorder that I don't know. I'll have to look it up.
I don't even know that one.
It's like your adrenal glands drain so much that it messes
Wow.
with your cortisol levels. I've heard it a few times. That's why I bring it up.
Huh.
I think it's more recognized in Eastern medicine
Okay.
versus a Western thing.
Sure.
Um,
Yeah.
Another one could be, there's so many variations of cancer too,
Yes.
right? So we might be like, okay, it's breast cancer, it's liver cancer, it's
Brain
brain
cancer.
cancer. It could be, what if I have a stroke or a seizure? Like, what if I have seizures? There's so many variations. I don't know if there's
Yeah.
anything.
No, you're absolutely right. And by the way, I just because we're getting a chat with the Instagram thing, this is all brand new,
Oh,
people.
okay.
Like there are
I
separate
don't see anything.
points on the Instagram feed versus the YouTube. So, um, Kevin Foss is here. Hi, Kevin. He asked
Yeah.
if it's the thing that that Eddie Izzard got. And I don't know. And then somebody said adrenal fatigue, question mark.
Adrenal fatigue.
Was
That's
it
it.
adrenal? Okay, there you go.
Yeah.
Yeah, so that could be a concern. Back to the cancer things. No, I mean, it's just any way that you could get sick. And so we see this happening too with things like, and we should probably do episodes directly tailored to this, but like mental health anxiety, right? Concerns that you're going to contract or you have some sort of mental health diagnosis. But like people are sometimes afraid that they're going to get dementia or that they're going to get Parkinson's or Alzheimer's, like some of these neurodegenerative sort of diseases. I've seen ALS come up. Like, oh, is that a twitch or is that just me feeling something in my body? Or so, and then you can see where also it's like, oh, well, I forgot this. Does this mean that I have dementia or that I have Alzheimer's? And we can see this coming up by proxy too. Like, what if my loved one or family member has cancer, or maybe like a recurrence? You can see this happening if like they've experienced cancer in the past and it's like, oh, well, but what about now? Or what if they get Alzheimer's or what it like,
yeah, it's actually not. I do see that. I do see for individuals who maybe have had actual legitimate health issues themselves, where they then become obsessed around what if it comes back or what if this thing happens again.
Yeah, and dovetails into trauma, right?
Yes.
Yeah.
Exactly.
Yeah.
Exactly my thoughts.
Yeah. And so just for those who are watching, I think I can speak for both of us probably, but you can fill in the blanks of whatever I missed. But basically the idea here being that like a discrepancy between a trauma response to an experience versus OCD is that sometimes the OCD isn't really generated by any sort of happening in the past. But for somebody who has this actual experience of struggling, with cancer or with something else, that it's, there's a lot of concern sometimes about what if it happens again. And yeah, somebody in the chat said trauma and OCD can co-occur together. Absolutely. And
Right.
Realistically, treatment for both is, can be, depends on your lens. But I think, again, our tendency is to go through the prolonged exposure lens for somebody who's dealing with trauma, which is in effect very similar to exposure and response prevention therapy.
Right. Exactly.
Yeah.
But I mean, I think there's a certain level of people where they've had some type of physical issue or concern, and then they have, they worry from time to time, versus somebody who's, let's say, had cancer, gone into remission, and now they're in our office and they're full on checking lymph nodes, checking for symptoms of that, going to doctors excessively, getting MRIs, CT scans. Like, okay,
Yes.
that's definitely not, I mean, it could be trauma related. That makes perfect sense, but it very clearly is also OCD,
Yes.
where the traumas it just really informed the OCD, in my opinion.
Right. Absolutely. And it can be hard to disentangle them at that point, but you're absolutely right that it's a response that's beyond what we would typically see for
Mhm.
somebody who's in recovery or remission,
Right.
since we're using cancer from cancer.
Mhm.
um, that it's excessive, and perhaps more importantly, it's interfering with life. So whether it's, and I think that that's the thing, is whether it's because something happened before or just because you're having a lot of thoughts in your mind about it. Either way, it's interfering with your life,
Yeah.
right? If you're responding to those thoughts by
Right.
trying to manage and control. Um, and it's interesting. Somebody said here, I think it's important that an OCD therapist acknowledges the person's trauma with medical events and not just say it's OCD, because that's minimizing the person's actual experience.
I
And
couldn't agree more.
I totally agree. And I also think I'm going to go a step beyond that and say, I think it's important to acknowledge that the person with OCD is genuinely afraid of something that could happen, because I don't think saying it's OCD should de facto minimize the experience.
Exactly.
We're
It shouldn't.
all, yeah,
Exactly. And it also the fact that this is scary and it could happen.
right, right. Like, I don't know what
Yeah.
percentage of the population gets cancer, but a fair amount does get cancer,
Right.
right?
Right.
And the reality is that we are all ultimately headed in the same direction, right? So something will get us eventually. And
Mhm.
learning how to be with that fact is something that we're all dealing with, whether or not we've had this scary experience historically.
Yeah.
Um, yeah,
It's certainly not our job to pathologize somebody though, because if they don't have trauma and we just assume that there's trauma, we definitely want to check in on that first and then
yeah,
have space for that and compassion and, really
yeah.
clarify how this all makes sense, that obsession has now become this. So it's a lot
Yes.
of validation in that
I was
process.
going to say, yeah, you're so right, because validating correctly, right,
Yeah.
is going to depend on the person's life experience. So if somebody's
Yeah.
had that, like had a diagnosis, had to contend with that, then validating their experience is going to involve acknowledging all of that, versus somebody who hasn't had that experience. Validating the anxiety is going to look like, hey, of course you're anxious. Mortality is scary. Like, makes
Mhm.
total sense, but it's going to depend on what the person's experience is.
And also really quickly, Mike, I have a question for you.
Yeah.
What about the bottom line, like the core fear here? Because
Mm,
if we're thinking about somebody who has a fear of like, what if I can like have some type of STD?
mm.
Let's see, right, where they're like obsessively checking their groinal area and they're looking for symptoms and they're taking photos and looking online.
And
Is
consulting doctors
in
and
consulting doc,
or avoiding them. Yeah.
right, or avoiding them. And then somebody who has, this fear of cancer.
Mm.
Do you see a difference?
Yeah. I think there absolutely can be. And I really want to hear your thoughts on this too. But initially, I'll just say that somebody with fears about STDs, for instance, oftentimes I'll see that being related to, what if I infect my current partner? What if I infect my children? Right? Unknowingly or unwittingly. I have to test, I have to check, because if I do have an STD and I don't know it, then that could harm somebody else. So, like, the fear is that you're going to harm somebody else and you'll never forgive yourself, versus there are people who are like, and then I'll die and I won't get to live my life and it will be horrible, right? Like, that's the sort of
I'll leave my
central.
children behind and my partner and my
Yes.
family.
Yep. Yep. And I'm not ready. I don't want to die, right? Like, all of those sorts of things. So it can be very varied, but for everything from sort of moral scrupulosity to
Yes.
existential concerns.
Yes.
Yeah. Yeah.
Definitely. That was what I was gonna say is, yeah.
Do you see any other, like, any other core fears jump out of you, or like sort of central fears?
Hmm. I think it all comes down to those two. I could
Mm.
be missing something. I mean, there could be some variation, there again, these can't be contained, but I think those are the main areas of concern.
Okay, so this is really nerd talk and
Okay.
interesting, but I just reflected on our past episodes about sexual orientation OCD, and the fact that this came up in that context as well, that we were talking about how oftentimes sexual orientation OCD will boil down to either an existential concern that you're not going to live your life fully, correctly, to its utmost, and you'll be dissatisfied at the end of the ride, or on the other hand, this moral scrupulosity, this concern that you're going to harm somebody else, that you're going to uproot their lives.
Yeah.
So it's just interesting to notice that like these two very divergent themes do kind of share that commonality. And I wonder, and I think actually I was talking to Kevin about this last week. Kevin, if you're still here, you can chime in. But the fact that I think John Hirschfield hypothesizes that all forms or subtypes can be broken down into a form of moral scrupulosity.
Mhm.
But I don't know. It's just sort of an interesting piece that like what we're seeing here is that perhaps a lot of different subtypes or several subtypes anyway can be broken down into both either existential or moral scrupulosity.
Interesting. Yeah. He definitely says that. John
does. Yep. Okay. I thought that was, yeah. Somebody said, how can you help someone who is always thinking they are sick? And this is going to be a whole series. So we're just talking today predominantly about obsessions, right? And the thoughts that pop in commonly with this particular subtype. But I think from that vantage point, one of the central things that's helpful in recovery is helping people to see that their thoughts are thoughts and not necessarily facts.
Right. This is true.
So how might you do that? Like if I came into session and I'm like, okay, I had this thought that I could have cancer and I'm really anxious about it. How would you help me to see that
but we're talking about a loved one, and I don't know if it's the loved one's job to necessarily.
Ooh, that's such a good point.
Yeah, to like hold their hand, because that's where burnout occurs, but I do want to touch on that. But
can I quickly say something too?
Yeah.
Also, obviously, like we can't give advice directly on here because it's not therapy. So, if your loved one has a therapist and you're willing to the extent that you can collaborate with the therapist to support your loved one and your loved one's on board, we would want to defer to them as well. These are just sort of general ideas.
Yep, absolutely. And I think there's a huge component of like just validating fear, right? Like when you're dealing with a loved one and supporting them is like, I can tell you're scared. I know you're scared and I'm here for you. Or how can I support you? Or I don't want to give in too much to this, right? Like I care about you and I love you. What would be helpful in this moment that's not compulsive? That's around after you've had this conversation, though, where the person's very clear on this is OCD. And yes, I'm very aware and willing to talk about it, because not everybody with an obsession is willing to have a conversation or have really high insight into here's this, and I believe that this is OCD. In fact, I would say this subtype, you're going to see much lower insight in individuals.
Right. Probably because there is such an overlap. Like these things are more likely to happen, right? Like people can't dismiss them as readily. Like you take COVID, for instance, like, well, what if I get COVID or what if I get long COVID? Like those are things that happen. So you're right. I think people are more fused or like sort of bound up in their ideas and their fears. So, but you make such excellent points.
Well, that, and also they get hyper fixated on the symptoms and almost can generate symptoms, right?
Yep.
Like, if you see someone yawn, then you start to yawn, which I know is actually not I think that that's actually a biological response, but that's just an example. It's like if I have a client telling me that they're having a hard time breathing, I'll notice like, okay, I'm having a hard time breathing now. All of a sudden, like I have to check myself.
Yeah, absolutely. That you start sort of like checking in with your breath, and then all of a sudden you feel things and you're like, is that normal? Because before you weren't really paying attention to your breath.
Yes.
Yeah, I think that
It's harder to ignore them. It's harder to come back to, like, with the reality of,
yes.
I don't know.
Yes, it is harder to, and I think that comes back to the fact that, like, one thing I want to call out is this idea that thoughts are thoughts, right? If you have a thought, like I could have cancer, that recognizing that thought could be fact or fiction, right? But ultimately it's a thought, just like a book or a movie can be based on a true story or totally made up. Right.
Yeah.
And so recognizing, okay, we want to just be able to look at this thought as though it's a thought instead of treating it immediately as though it's a fact.
Right. And noticing and noting that this thought generates this feeling, which is anxiety.
Yes.
Being like, okay, anxious or anxiety.
This is anxiety.
Right. And then we have a choice. How do we want to respond to it? Because not sometimes, a lot of times people think because I'm anxious, it must be true. Right. So there's a lot of emotional reasoning that goes on.
Yep.
And so instead of doing that, we go, oh, look, just because I feel this doesn't mean I have to respond to it. It doesn't mean that it's super important. It doesn't mean that this is truly happening. Right.
Right.
Fear is saying your life is in danger.
Right.
And when that's activated, it's really hard with every cell in your body to say, you know what, maybe I just gamble this and see where this goes is really hard to do, guys.
It is really hard to do.
Hard.
Your amygdala is like, warning. And you're like,
your life is in danger. You're going to have cancer. You're going to get a blood clot. You're going to die any second.
Right. It's
terrifying. A really scary thought.
It is. And I think one thing to keep in mind there too is that you're trying to reason with a part of the brain that's nonverbal
and totally non-negotiable. It's the imp of the mind.
It's the imp of the mind. And once it's set off, it's gonna do its thing until it like resolves of its own accord. So any like, I'm gonna like now try and fix my amygdala and stop it from firing, it's not gonna work.
Yes.
That's why one of many reasons why compulsions or safety behaviors, trying to make sure that you don't have whatever you're afraid that you have, is not like excessively make sure that you're not afraid, that you don't have what you're afraid you have, doesn't make sense.
Right. Exactly.
But, and this is probably something we'll touch on more with the compulsion side of things or safety behavior episode, which is next. But with this subtype and with all, to some extent, it's important to say like, okay, well, what's not excessive? If I am having
reason.
Yeah. If I'm having physical symptoms, then, maybe I go to the doctor once, right?
Yeah. Maybe. We'll spend a good amount of time, I think, on that in the compulsion section. So hopefully look forward to that.
Yeah. I will hope you'll join. One thing, we've got 2 comments here about, well, let's just take this one because I know we're getting close to being out of time. But somebody said, can meditation help with OCD? Do you want to field that?
It certainly can. I mean, that's kind of what we were just saying, like noticing thoughts and noticing feelings without judgment, which is kind of the core of mindfulness and meditation. It's not going to solve OCD, to be clear. It's not going to make OCD go away. It's going to allow objectivity and slowing down your response time to it. And it takes a long time to get there.
It sure does. It takes a lot of practice to slow down in the face of the warning signs going off.
I can support you greatly, though, over time.
Agreed. And somebody else was saying negative thoughts. I have negative thoughts as soon as I wake up. I repeat to do certain actions until my negative thoughts turn to positive thoughts. And, you could certainly see this coming up in pretty much any subtype.
Right. It's just that's totally a mental compulsion.
Right. I mean, in theory anyway, it sure sounds like it. And,
Right.
you know, the trying to, I'm going to just do this until I have a good thought. It's like, but what else could you be doing with your life in that moment?
Yeah.
Right? Like, could you be doing something else that means more to you than just trying to have a positive thought?
Right.
Because I bet there's a big world out there.
And the more you push it away, the more it'll come back, ironically. So,
Yeah. Yeah, for sure.
yeah. Okay.
Well, I'm looking forward to having our discussion on part 2 with regard to the compulsion side of things, and we'll definitely be talking about treatment because somebody asked a question about treatment in the third installation, which will be not 2 weeks from now, so 4 weeks from now. 2 + 2 = 4. I don't know if you know that.
I actually just figured that out right now when you said it.
Oh my gosh, we're geniuses.
Yeah.
So yeah, 2 weeks from now we'll be talking. Yes, is that right? 2
Yeah.
weeks from now we're talking compulsions, and then 4 weeks we'll be covering recovery and treatment. But thank you for a robust discussion today, everyone. Thanks for coming.
Thank you.
And yeah, as always, feel free to send us messages with requests for things to cover. And yeah, we
Yeah.
will look forward to seeing you next time.